titled Reducing the Risk of Medication-Alcohol Interactions in Older Adults. This is the first webinar in our 2015 Mental Health and Aging Training Initiative series, initiated by the Virginia Geriatric Mental Health Partnership. The Geriatric Mental Health Partnership, in collaboration with Riverside Center for Excellence in Aging and Lifelong Health and VCU's Department of Gerontology, is organizing this series of webinars dedicated to mental health and aging training. This webinar will address medication and alcohol interactions in older adults and how they can have a significant impact on health and well-being, as well as other chronic health conditions. This event is made possible through a grant from the Virginia Center on Aging's Geriatric Training Education Initiative and supported by Riverside Center for Excellence in Aging and Lifelong Health, the Virginia Geriatric Mental Health Partnership, and VCU's Department of Gerontology. We're fortunate today to have as our presenter Dr. Patty Slatem, who is professor in the Department of Pharmacy at Virginia Commonwealth University. I'll refer you to the webinar hub for her bio, series summary, and additional details and contact information. Thank you to the Geriatric Mental Health Partnership Planning Committee for their efforts in securing these topics, as well as our presenters. As always, I'd like to thank Nico Stanculescu from World Events Forum, who is our platform facilitator, as she spends countless hours behind the scenes to bring these educational opportunities to you. And I'm Ann Welliford, your moderator, chair of VCU Department of Gerontology at Virginia Commonwealth University and a member of the Mental Health Partnership. I'd like to share a couple of housekeeping items before we begin. First of all, the slides are available for downloading. I understand that some folks have already done that. This is available so you can take notes during the sessions. Please be certain to complete the survey that you will receive following this webinar. This survey enables us to keep these educational offerings to you for free from our funder. This is also how you will receive your certificate of attendance. Throughout this session, we will be holding several interactive polls, so please stay alert for those, for both polls and opportunities to post questions and answers. We are very eager to have your comments, so please stay tuned. We'll be extending this session briefly to allow for questions and answers for our attendees, so please stick around through the duration of the session today. Thank you for your attention to these logistics. And now I'd like to turn our attention over to Dr. Slatem.
Okay. And good afternoon, everyone. This is Patty Slatem, and we're going to spend a little time this afternoon talking about opportunities to reduce the risk of medication-alcohol interactions in older adults. Some of the objectives that we have for this afternoon are to identify medications that actually do have these interactions and what the potential outcomes when alcohol and these medications are mixed that can occur in older adults. We'll talk about risk factors for adverse events, and especially those that result from alcohol and medication interactions among older adults. And we're going to focus on three special issues in treatment where this interaction between alcohol and medications can become an issue. One is pain, one is, and falls, of course, resulting from that, depression and insomnia. And we're also going to use case studies as a way to work our way through thinking about these issues. And that's where the interactive part will come in. So I'm looking forward to your feedback as we go along on those case studies. And we're going to start with a case study as a scenario of a patient named BW. And I'm sharing this at the start so that we all can have a picture in our mind about what some of these patients look like that we're going to be discussing today. BW is a 93-year-old white male, and he was married for quite a while, actually. For 71 years he was married to the same individual, and he lives with her independently in a small apartment. She's blind and has a lot of impairments and functional limitations that really require BW to step in with a lot of assistance with activities of daily living. So the two of them are living independently, but BW is shouldering a good bit of the caregiving and the day-to-day activities within the home. And he no longer drives, but he does have 3 sons. They live nearby, and they help with errands like grocery shopping and doctor's appointments. Now, he himself suffers from some chronic health problems. He has heart failure or congestive heart failure, atrial fibrillation, osteoarthritis, and he was recently diagnosed with depression. And his medications that he was taking are listed there. So he takes furosemide, which is a diuretic, potassium to replace the potassium that's lost because of the diuretic. He was taking digoxin and for his heart failure, warfarin as an anticoagulant or blood thinner. Sertraline was recently added as a medication for depression, so it's a selective serotonin reuptake inhibitor for the technical names. And he also was taking Tylenol or acetaminophen 4 times a day as needed when he was having this arthritis pain. So although his medication list is not as long as many that we might see in some of our older clients, he was taking some high-risk medications, including blood thinners. Now, over the past several months, BW was running into some difficulties managing everything at home. One thing in particular was his warfarin or anticoagulation therapy. And his INR, which is the blood test for measuring how thin his blood was fluctuating above and below the target range. He was going in for multiple appointments to get adjustments made, and he finally told his doctor he wanted to stop taking all of his medicines. He was tired of all the monitoring and the dosing changes, and it was just too hard to manage all of that. And his functional status was declining. So his family hired a companion service to come in and assist him 3 mornings each week. Now, after working at the home, the companion had been there for 2 weeks. She reported that to the son, and this was to the oldest of the 3 sons, there was empty alcohol bottles in the trash can. Well, the son didn't think too much about that because his father had asked him to purchase a bottle of alcohol because he had some friends coming over. His old buddies from when he had been in the war were coming to visit, and he felt it was appropriate to share a drink with them. And meanwhile, BW has this long history of episodes of alcohol misuse in his life, but in recent years, actually the most recent 15 years, he'd been abstinent from alcohol. And that was because he fell down the stairs and broke his arm while intoxicated, and he had a big wake-up call, I guess, so to speak, and he had stopped drinking. So the son had purchased this bottle of alcohol because of the friends that were visiting, so he didn't think too much of it at the time. But over a very short period of time, BW began to have health complications from his heart failure. His lower extremities, his legs had become quite swollen and edematous, full of fluid because his heart failure maybe was worsening. He fell 3 times, and after falling, he would call the ambulance transport, and then when they got there, he would refuse help. Just get me up off the floor, and then he would refuse to do any help. But the 3rd time he fell, he actually was unable to get up and was transported to the emergency room, and he was admitted to the hospital for a heart failure exacerbation. So he did finally end up in the hospital. And so while he's in the hospital, his sons call a family meeting because we have to figure out what they're going to do with their mother while their father is in the hospital. And they wanted to discuss what the living arrangements would be longer term. And what they discovered during these meetings is that each of them had been purchasing alcohol for their father over the past few months, that neighbors and grandchildren had also purchased alcohol for him, and when all of that was put together, it appeared he might have been drinking as much as 9 ounces of bourbon per day, while the family thought he was really abstinent at this point. So with that scenario in mind, and remember he's also taking a number of prescription drugs, let's think about what are the implications of the aging body, about medications, and how all of this can, when combined with alcohol, result in adverse drug events. So as we age, our bodies do experience a lot of physical changes, and they can impact what happens with medications in a couple of ways. One is they can influence how drugs get in and out of the body. So how effectively they're absorbed, how well the kidneys or the liver, depending on the drug, are able to get that drug back out of the body. What also changes is how the body actually responds to the drug that's present in the body. So you can almost think of aging as a way that often increases the exposure to a medicine, so it stays around longer, or the concentrations of it in our system are higher, and then the body may have an exaggerated response to the medication levels that are there. So not only is the exposure higher, but the response can be exaggerated. We also know with aging that the composition of our body changes. And I don't really like to be reminded of this, but we do become more fat and less water as a proportion of body weight as we age. And this is true even for conditioned athletes, that just the proportion of our total body weight that is body water is decreasing while the body weight is increasing. And this is particularly important for alcohol because alcohol distributes around our body in our body water. So for the same drink, or the same dose, if you want to think of it that way, of alcohol, we end up with higher blood alcohol concentrations the older we are generally for the same drink. So not only are we potentially experiencing increased exposure to medications that we're taking, but we may also be experiencing higher blood alcohol concentrations for the same drink than we did when we were younger. And so we're having more of the medication around and potentially higher concentrations of the alcohol around for the same things we may have engaged in when we were in our middle age. And this is actually pretty important for explaining why, at least in my experience, my older patients tell me that they feel the effects of alcohol more. This is one of the reasons. We also have these changes to kidney and liver function with aging, and although they are important for alcohol, they are particularly important for the other medications. These are the primary ways that medications get out of the body. Drugs do take longer to get out, and so older adults may need lower doses or a longer time period between doses of medications. And when we add alcohol on top of this, it can actually make the situation worse. Probably most importantly for alcohol is that with aging, we also have changes in that drug response. So even if you had the same blood alcohol concentration that you did maybe when you were, that you had achieved when you were younger from the drink, your brain responds more intensely. And part of that is because our ability to counteract the effects of medicines decreases as we age. Older adults are often more sensitive to medications and less able to compensate for the effects of medicines that are put in the body. And you know, if you take a medication to lower your blood pressure as an example, your body tries to keep your blood pressure, you know, in a normal range. It tries to prevent it from going too low by all of these counterbalancing mechanisms we have in our body. So alcohol can add to this sort of physiologic change that happens with aging that makes it we're less able to compensate. And so we can end up with unwanted effects of medications and alcohol because of this change in response. And where this has been demonstrated to be the most significant thus far in what we know about the aging process is the impact on the brain. So things like our balance and our ability to keep our bodies upright and not falling are all impacted by aging and by medications that affect the brain and by alcohol. So we can get sort of a cumulative effect going on here. And when we think about adverse drug events for older people, sometimes the adverse events do appear in a little different way than they would in younger individuals. And so symptoms like an altered mental status or confusion, fatigue, experiencing falls, incontinence, dizziness, this is often how adverse events actually show up. For an older person, they are a geriatric syndrome. And we know that geriatric syndromes have many potential causes, but medications can be one of them. They are more common with aging, but they should not be considered to be part of normal aging. We may be more likely to fall in our later years, but they're not necessarily a consequence of just aging itself, or to be assumed that they can't be modified because they're due to aging. We can make changes in things like medications that can reduce the risk of falling. We can do exercises that increase muscle strength that reduce the risk of falling. So these are often risk factors that help us to have or cause us to have these problems can be modified. And I think, it's not always a direct connection when someone falls that we immediately think, gosh, this could be due to their medications. And maybe when alcohol is mixed with medications, these effects can be exaggerated. So I'd like to talk for just a minute about drug interactions themselves. When we take medications with foods, with dietary supplements, with over-the-counter medicines, with other medicines, all of these things have the potential to interact with each other. And what we know is that the more we increase the number of medications that are being taken, we get an increased risk of having a drug interaction that results in an adverse drug event. So anytime we mix medicines, there is some risk that an individual person will experience an adverse event. We know that for some drugs the risk is higher. We know the more of these drugs we mix together, we can get a higher likelihood of something happening. And in the context of drug interactions, I like to think of alcohol similar to just another drug. It's another chemical, if you want to think of it that way, that we're putting into the system that has the potential to interact with the other things that are also being taken. And really, drug interactions are not a yes or no phenomenon, that they either are or are not happening. It's almost like a graded response, and we can't really prevent them all. Matter of fact, we use medications together frequently in caring for someone with multiple chronic health conditions, and that happens perfectly safely. But for some individuals, they're at higher risk of having an adverse event because those things are mixed together. So it would be nice if we could just say, well, we know these medicines interact and they should never be mixed, but it isn't as simple question as that. And so we know that some people are going to be at higher risk. If you're taking multiple medications, you're higher risk. If you're seeing more than one doctor, you can be at higher risk because of coordination of care and potentially duplicating up on things. Patients who are infrequently or not getting monitored often enough also can run into a problem because the adverse events aren't recognized for what they are, like falling, for example, may be attributed to something different than medications when there's not adequate monitoring of those medicines. And of course, if your kidneys or your liver are impaired by diseases as well as potentially aging, you can have an exaggerated effect. We also have to think about all the things that, we talked about this a little bit, but dietary supplements, herbal products, over-the-counter medications, and alcohol all have to be considered in the mix of when we're evaluating drug-drug interactions. And pharmacists do look at drug interactions when they fill prescriptions. But what they are looking at is the medications that they know that the individual is actually taking because they're sitting in a computer system somewhere, or they're the patient or their family member tells the pharmacist that they're taking them. So we have to remember that pharmacists often don't know what over-the-counter medications or dietary supplements that their patients might be using, or whether or not they're consuming alcohol with their prescriptions when they do that drug interaction check. So one thing is to make sure that if we're going to have our medications screened for drug interactions, that we're actually including all of the factors in that equation that need to be there. and informing the pharmacist or asking the pharmacist to do this as part of the drug interaction check to look at those other products along with alcohol. We know that some medications have a particularly high risk of an adverse event when they're mixed with alcohol. And we're going to focus on 3 categories of medicines where this occurs, and then I'll briefly talk about some of the other more unusual things that fall in the drug interaction category as well. So when we mix alcohol with any of the medications that impact the brain, they're often called psychotropic drugs, but these are things like sedatives, pain medications, antidepressants, anti-seizure medications, things that are also acting on the brain. We can often get increased sedation, unsteadiness, or falls related to mixing alcohol with those drugs. So those drugs in and of themselves are high risk for, or increase the risk for having a fall for an older person, but when you mix alcohol with them, that risk is even higher. So alcohol does have an additive almost effect. Some would say it can be more than additive with sedatives and other drugs that act on the brain. This would be things like Ambien and Valium, where we know that we often hear instructions, don't take alcohol with these drugs, and then we hear about cases where this is actually occurring. And we'll talk more about that. The next class or type of interaction that I want to spend a minute talking about is when alcohol is mixed with what we call nonsteroidal anti-inflammatory drugs. These are aspirin, ibuprofen, naproxen. There are a host of prescription medications that are also nonsteroidal anti-inflammatory drugs. They're usually used for management of pain or inflammation. Aspirin might also be used for protecting the heart. And what happens when alcohol is mixed with these medications? These medications in and of themselves increase the risk of experiencing a gastrointestinal bleed, so a bleeding event. And bleeding events can be very serious, even fatal occurrences. So these drugs can cause those, especially if you're using higher doses of them. But when alcohol is mixed with these agents, it increases that risk even further. So what we're worried about when we mix, Motrin, which is ibuprofen, or Aleve, which is naproxen, with alcohol, is that we can increase the risk of actually having a gastrointestinal bleed. And it turns out that older adults are at much higher risk of this than younger populations already. So that is another area where we particularly want to pay attention. The age group that has the most osteoarthritis is older adults, and then we turn around and mix alcohol with those, we can run into a problem. A third area of particular focus for older adults is mixing alcohol with blood pressure lowering medicines. So alcohol can lower blood pressure, especially right after it's consumed, can cause the blood pressure to actually go too low. It's like the medication is there also lowering the blood pressure, and the blood pressure drops to the point that the person may experience a fall by having what we call orthostatic hypotension. When they stand up, their blood pressure drops really low and they can't stay upright. So we also have concerns about that. Now there are other classes of medications, some antibiotics for example, that when you drink alcohol with them, those medications actually prevent the breakdown of the first metabolic byproduct of alcohol's metabolism, and so acetaldehyde accumulates and it makes you feel sick and it causes nausea and vomiting. Usually for those medications that cause that kind of a reaction, an antabuse type reaction they call it, it'll have a label that clearly says do not consume alcohol because it makes you physically sick because of acetaldehyde accumulation. So those things are important too. They occur in all age groups, but we're going to focus primarily on these 3 categories that we were just talking about for our case studies. Oh, and before I move ahead, I'll just mention there is a brochure or information available from the National Institutes of Alcoholism and Alcohol Abuse. The reference is there on the slide where you can get a complete list of all of these interactions. just for your reference. Tylenol is also an issue with alcohol. Tylenol is found in a lot of products that are available over the counter. As you probably know, we have recommendations for the maximum dose per day, not to exceed 3 grams or 3,000 milligrams per day. And the effects of alcohol use on acetaminophen or Tylenol are rather interesting because it depends on the pattern of the alcohol use, what kinds of adverse events you might expect. And so I just wanted to point this one out. Young people often take Tylenol and water to try to prevent a hangover after consuming alcohol. But for older adults, it may be more of a situation of trying to manage pain by combining Tylenol and alcohol. And in this case, when the Tylenol or acetaminophen is taken during or right after drinking, it increases the risk of damaging the liver. So the major side effect that puts the limit on the dose of acetaminophen is liver damage. And of course, in an overdose situation, that can be fatal. If we are going to, if we take acetaminophen during or right after drinking, we get increased risk of liver damage. Chronic drinking can increase the production of these toxic metabolites as the liver is breaking down acetaminophen, these toxic ones, and cause a different kind of damage to the liver. So it matters whether or not it's right after drinking or the effect of chronic drinking has on the liver itself, because chronic drinking will sometimes rev up the enzymes of the liver in the start, and then it may make them actually not functional to some degree too, if damage is being done to the liver by the alcohol itself. And that's a little more than we want to get into talking about today, but realize that mixing Tylenol with alcohol can harm the liver and make that damage happen at lower doses of the Tylenol. So I usually recommend to my patients not to mix it together for my older adults. So when we look at the treatment issues around some particular health conditions, where it's more common sometimes for alcohol to be mixed with prescription drugs that can be harmful, then that's, we're going to spend a little bit of time looking at some case studies to illustrate these points. So if we move to looking at pain, many medications are recommended to manage pain in older adults that interact with alcohol. We've already talked about acetaminophen or Tylenol, non-steroidal anti-inflammatory drugs, which are like Aleve and ibuprofen and the prescription medications, and also opiate analgesics, like you know, your Vicodin and such, that these medications all can interact with alcohol, mostly to increase the risk of experiencing a fall, unsteadiness on the feet, balance issues, things that are for the opiates. For non-steroidal anti-inflammatory drugs, it's the increased risk of a GI bleed, and for acetaminophen, we're talking about increased risk of liver toxicity if alcohol is actually mixed with these. And we know that some patients actually do use alcohol to self-treat pain and may be using these things together. The interesting, or the complication here, I'll just say, is that because acetaminophen and non-steroidal anti-inflammatory drugs are available over the counter, patients rely often on the information that's printed on the box of those products when they are deciding whether or not it's safe to take them, what the dose should be, and whether or not it can be mixed with alcohol. And the messages on those bottles are sometimes not clear. They may say things like use caution, and we all know that can be interpreted in many different ways. It may say, not on non-steroidal anti-inflammatory drugs, for example, it says don't exceed more than 3 drinks along with with the non-steroidal anti-inflammatory drug. But those 3 drinks would be for a younger person, not for an older person when it comes to the gastrointestinal bleeding risk. So it may be that the messages are not age-specific, and it also may be that they're vague. Many times it just says, ask your healthcare provider. And we might ask, how well are our healthcare providers informed about how much alcohol is okay to be mixing with medications as we age. So let's look at the case study of LR. LR's primary complaint was dry mouth. And boy, was she complaining about it for several weeks. She was living alone in her own home. She was having difficulty starting to do some of those IADLs, the instrumental activities of daily living. So the bill paying, the shopping for groceries, her daughter was having to become more involved with these. She was, LR was dozing off during the day, and she seemed a little unsteady on her feet. But when her daughter tried to talk to her about these things, she, of course, was defending herself and claiming that these were normal for her age, to stop getting in my business, and she was really very resistant to talking about it. But boy, did she want to talk about dry mouth. That was actually how I met these folks, because I think the daughter was at her wit's end about the dry mouth. So she'd asked 3 different doctors about the dry mouth. I mean, different practitioners that she sees. But only recommendation she really got was to suck on hard candy and to drink more fluids. And she didn't really feel like these things were helping her. And so her daughter asked for a medication assessment to see if her medications might be causing this dry mouth. So here's her medication regimen. And although we probably today don't have time to go through the details of all of these medicines, I'll just point out that gabapentin or Neurontin she was taking multiple times per day. That is a medication that can be used sometimes for neuropathies or for chronic pain, but is also considered a psychotropic, or one of those drugs that acts on the brain. She was taking a diuretic, furosemide, along with potassium. She was also taking a beta blocker, metoprolol, for her heart. She was taking duloxetine, or Cymbalta, which is an antidepressant but is also sometimes used to manage pain. She was taking oxyprozin, which is a prescription nonsteroidal anti-inflammatory drug. And then at night she was taking Seroquel, which is an antipsychotic. She was also taking amitriptyline, which is a tricyclic antidepressant for pain, and temazepam, which is a benzodiazepine, which is a sedative for sleep. And if you look at her regimen, there was one medication that had been added most recently, and that was the Cymbalta. And if you, and I'll mention that if you run a drug interaction screener on her medications, you would see that Cymbalta actually interacts with amitriptyline, and it increases the concentrations of amitriptyline in the body. Amitriptyline is a tricyclic antidepressant. It's also a drug that blocks the neurotransmitter acetylcholine, so it's anticholinergic, and one of the side effects is dry mouth. So she was already experiencing a potential drug interaction, and it turned out that when the Cymbalta was stopped, she in fact stopped having the dry mouth. Actually, the Cymbalta and the amitriptyline were stopped ultimately, and that symptom recovered. However, her story was more complicated. So during the interview, she admitted to moving the times around of some of her medicines, and she was actually taking that temazepam or that benzodiazepine in the middle of the day and not at night, which might explain why she was dozing off in the afternoon, because she was taking a sedative at around lunchtime. And she also admitted to consuming some alcohol on most days of the week. She also was taking 1,000 milligrams of acetaminophen in the morning and before going to bed at night. So she really, besides her prescription medications, which had a lot of psychotropic drugs in them and nonsteroidal anti-inflammatory drugs, she was taking several things that put her at risk for having a problem when mixed with alcohol. And so now we're going to move to our poll. And when we look at the case of LR, what are some of the signs that she might be experiencing a problem related to medications? And you can choose as many of these as you think are relevant to her case. So all that are correct.
Okay, so this is your opportunity to show us what you know. The choices are new complaint of dry mouth, difficulty with instrumental activities of daily living, dozing off during the day, unsteady on her feet, and living alone. So Dr. Sladom says please choose all that apply. We'll give you a minute to jump into that. You know, one of the things that you're mentioning, Dr. Sladum, that I always appreciate in your presentations is that one of the first things that you need to look at for any new symptom is there a new medication that the person is on? And that certainly bears out in this case as you've described it. Very complicated, lots of things going on, but that's certainly one of the keys. Okay, take another minute here to choose your responses so we can see how folks are doing.
And after we get to that, we are going to look at some of the strategies and have you respond on some of the strategies that we might use to help LR. Because what happened in trying to uncover or discovering that she had this drug interaction, we also learned of some potential issues related to alcohol mixed with these drugs. And we'll talk about some strategies that might be helpful for her.
Okay. So it looks like folks' responses are 96% say new complaint of dry mouth, 85% say difficulty with instrumental activities of daily living, 94% dozing off during the day, 93% unsteady on her feet, and 26% say living alone.
Excellent. I agree with you. And actually,
for everyone.
Yay. So this new complaint of dry mouth was actually it seemed to be the direct result of a drug interaction. And although you don't know the rest of the story of her case yet, when they were stopped, I mean, the symptom did resolve. And so we have a pretty high suspicion that that was directly related to a medication-related problem. But when it comes to these other issues, dozing off during the day, being unsteady on her feet, these are clues that something is changing. And although there may be other reasons that are not due to medications that these things might be happening, we should have a suspicion level. Just like Dr. Welliford said, a suspicion level that medications might be involved. And even when someone begins to have trouble with instrumental activities of daily living, well, is this normal for aging, or is this potentially being caused by something that's modifiable? We should always have that suspicion before we assume that it is inevitable and part of aging. But as you recall, in LR's case, she did assume, or was trying to at least make the case, that it was her age that was responsible and it wasn't something to be worried about. One of the reasons sometimes I think that at least my patients seem to get defensive in these conversations is that they do feel threatened about the loss of things like their autonomy. She wanted, when asked, she said her goal was to stay in her own home. Now that, you start not being able to manage your groceries and your bills and these things, that can begin to feel threatened. And when symptoms like unsteadiness and dozing off and whatnot start playing a role, then that can be even more threatened. And it turns out that the dozing off during the day, I think almost everybody said that was an issue, especially when she's moving around the timing of her medicines. Unsteady on her feet when she's mixing alcohol with a number of psychotropic drugs. Those drugs on their own may have been causing that, but add alcohol, it can only make that worse when it comes to things like unsteadiness on the feet. Now, living alone, in and of itself, people can live alone, and that's not a sign they're having a problem, but it may make it more likely for a medication-related problem to occur. So the other way around, that they're not signs she's having one, but they may increase her risk for having one. And with alcohol, we know that it's often a hidden epidemic. So what strategies might we use to help LR? And here I'm thinking about things like, are there referrals that need to be made? Are there certain healthcare providers that would be of help here? What about her daughter and the role that she might have? So what kind of strategies might we use? We have particular medical strategies about her specific medications, but what are some of the things that virtually any of us can do in our roles in healthcare or as a family support or even as a family member? So I'll look for some of your ideas, yes.
So you'll notice a box over to the right-hand side where you can post your questions. This is also a place for you to post your strategies. So those of you who have experienced situations like this, which is probably everyone, so please take a moment to post these strategies, and we'll have an opportunity to share those throughout the rest of the session. Okay, so we have our first ones already rolling in, of course, and the first response is referrals to the community service boards and substance abuse programs that are available. Another one is to suggest that the daughter or LR herself to complete a weekly pill box. Several suggestions about pill box. Organize a team meeting between the doctor and the patient and the daughter. A medication review. Okay, they're rolling in faster than I can read now, of course.
Okay.
That's great. That's great.
Yeah. Well, let's start with some of those that have come in so far. And I agree that this notion of are there things that we can do to help her with her daily management of her medications, part of this may be education, part of this may be organization, like pill organizers, and it may also be in part trying to really figure out what the root of her issues are. When someone starts moving around the timing of their medicines and things, it makes me think that maybe we don't know the whole story. So what's driving this behavior to add alcohol to medicines, to move around the times of medicines? What is really at the heart of what's going on here? And this idea of having a team meeting between the daughter and the doctor, or of course, LR herself needs to be at the center of all of this, really trying to see if we can't get to the heart of the matter. Because LR is doing a little bit of hiding of information, and we do need to potentially get there, right? A medication review would be very helpful to see where are the areas where we could have some opportunity to make an improvement. And I think you can see a little bit from the case of LR that because there does seem to be something going on, and a lot of these medications are actually surrounding the issue of pain, and and control of pain. And it turns out that that was a big issue for her. And what she wasn't taking was any kind of an opiate analgesic. So she's taking nonsteroidal anti-inflammatory drugs, which are high risk for older adults and then higher risk when alcohol is added. She's taking a lot of antidepressants and drugs like gabapentin or Neurontin, which she was taking specifically for pain. And why did she move her sleeping medicine to the middle of the day? Was because of pain.
So you're suggesting that, rather than looking at strategies to alleviate the symptoms, to step back and say, why is she self-medicating? Because something about her current prescription regime is not working for her.
Yes, and she's gotten into a sort of a maladaptive way of coping with this problem that's threatening the very thing she cares about, which is remaining independent. Right?
Right.
So yes, it's first, we would never know this if we don't ask about alcohol use. We would never have really realized the extent of what was going on, I think. And it takes more than just the pharmacist or the doctor to solve problems like this. And there's roles to be played all the way around. We talked about CFBs. We talked about other kinds of health care professionals who could get involved. And she will need support and ongoing support to really be successful in changing this pattern that she's fallen into.
Mm-hmm. Excellent.
Okay? Mm-hmm. Yeah. All right, we will move on to our next scenario, which is about depression. And alcohol does interact with all the classes of antidepressants, so it's not like we can choose one that doesn't interact. And we know that antidepressants are a very common modality for the management of depression in older people. And matter of fact, sometimes they're far more accessible than the other services that we know would really probably be more valuable in the long run. But we're in this situation where antidepressants are often a first-line approach. Well, because major depression and alcohol use disorders increase the chance of having the other one. So if you have depression, you're more likely to run into a problem with alcohol and vice versa, that we should expect that there may be some co-use of agents going on. And it may even be that alcohol use disorders have a causal link with major depression. And what is actually best in treatment, the very best treatment approaches, are still to some degree unknown, although it does seem that a combination of antidepressants along with psychotherapy approaches are going to be better than either of those modalities alone. It's just the accessibility sometimes to the kinds of programs and treatments that people need really aren't available to some older adults. So let's take a look at a case, and this is the case of SP, who's an 82-year-old female, and she has COPD, so chronic obstructive pulmonary disease. This was because she was a smoker for almost 40 years, and then she was also a moderate alcohol drinker. And we know that smoking and alcohol use do go together, and really she was a moderate alcohol drinker. She wasn't someone who, was very excessive amounts of alcohol that she was consuming, but it was regular use. And she was diagnosed with depression, and she had been treated with antidepressants in the past. She moved into a senior living center, and when she got there, she started drinking more heavily, and this led to several falls, and she ended up with a fractured arm. And that's actually when I met her. So her prescriptions consisted of 11 medications. So she had a whole list of things, which you see with Advair, Mucinex, albuterol. These were all medications for her COPD. What that means is she's taking oral medications and inhaled medications because her COPD was fairly severe. She was also taking paroxetine or Paxil for depression. She was taking simvastatin for her cholesterol. She was taking supplements of iron and calcium. I couldn't really figure out why she was taking the supplements of iron. And she was also taking digoxin for heart failure, and she was taking primidone for a tremor. She had like an essential tremor. And it was bothersome enough to her that drug therapy seemed to be the treatment approach that was taken. But interestingly, when interviewed and asked what her health conditions were, she could report COPD for sure and depression, but she didn't mention the tremor or heart failure as part of her health problems. So if we take a look at her case, what are some of the signs that happened to her that she might be experiencing a medication-related problem? What are some of the things that were happening in her case? And we'll give you a minute to respond to the poll. Falls, the fracture, living in a senior center, smoking, or depression. You could pick all the answers that you think are correct.
All right. Take a few minutes to think about the response, or the responses. Tell us what you think. And are we going to ask folks for strategies on these two?
Yes, we are. Well, we're going to ask them for their recommendations on what,
excellent.
What we
so
can do here.
While you're choosing your responses, go ahead and start thinking about your strategies.
Excellent.
Okay. So it looks like, in terms of the responses that folks have, the highest response, 98% falls. Second in line, 94% depression, and then followed by fracture at 77%, and then smoking at 42%, and living in a senior living center at 24%.
Okay, so let's take a look at those responses. I would agree with you that this whole business of falling and fractures, we have to look and see whether something is going wrong here related to medications or to alcohol use. And it's interesting because the literature shows that about 20% of the time falls seem to be pretty directly related to a medication. So it's not all falls. She could be falling for some other neurologic reason, cardiovascular reason, environmental reason. But when someone begins to experience falls like that living in a retirement community, we should have a laser beam on that of thinking something that might be modifiable here that could make a difference. So those signs of falls and fractures are particularly important. Depression is also one of those things that can either be caused by medications. It is more common in people that have chronic health conditions like COPD, and might be a sign that alcohol consumption is getting worse. And we talked earlier about smoking kind of being concurrent with that. People with a long history of smoking may also have a history with alcohol, or they're more likely to. Not always, but they're more likely to. With alcohol in particular, this issue with living in senior centers has become a new, I guess, topic for us to be thinking about, and that is, as the baby boomers have reached the age of considering moving to retirement communities, the accessibility and the social desirability of alcohol in the environment is increasing. And you see this with retirement communities offering happy hours and doing this, which is part of the social dynamic that baby boomers in particular are seeking. And we might say, well, that's a personal choice with, and we do say that is a personal choice of the autonomy of individuals, and has health benefits that may be associated with it as well. I think the difficult part for a lot of us is figuring out what to do to help people make informed decisions when they're mixing that alcohol with prescription drugs. I just don't think we do a very good job of helping people to understand what those risks really are. And maybe not in the information we provide them when they pick up a prescription from the pharmacy, not in the time we spend with them and in an encounter when that prescription is originally written. And it's just more and more a part of the culture to consume alcohol on a regular basis while these chronic health conditions are being treated with medications. So I'm interested in what recommendations you all have for SP.
Well, it's interesting that you're talking straight away about the importance of education, Dr. Slatem, in terms of, particularly in relation to moving into a senior living community where sociability and alcohol consumption might be part of the norm of the establishment, and making sure that people are aware of how your body changes and how that might be different for you about alcohol consumption. So education has come up multiple times already in terms of this case, and medication review, and let's see, here we go. What the goals are for her own health in terms of motivation.
That's very important. Yes. I like that.
And looking into the support network that SP has. And, that was actually one that came up in the previous case, too, in terms of increasing social interaction as part of medication management.
Yes, but it turns out in the case of SP, we do have a direct interaction with the paroxetine and the primidone in particular, but it kind of goes far beyond just what the medication regimen is, and really what's leading to the mixing of these medications with alcohol, and why the increase in alcohol use at the time of a big life change of moving to a retirement community. And
so it seems like in both of these cases it's about, looking back to the beginning. Is that what you're suggesting? What is the reason behind all of this? Yes.
Exactly. All right, you all are doing remarkably well here. That's excellent. Yay! We've got one more to cover here, as we're getting close on time, I think, and that is insomnia. Alcohol interacts with a lot of sedatives and these are what we're using to treat insomnia from a medication point of view. I think it's become pretty clear that medications are not the first go-to option that's desirable for managing sleep problems for anybody, but especially older people, that dealing with those sleep hygiene things, which are listed there, are actually, they work better, and they don't have a lot of the complications that these sedatives have. But alcohol is one of the medications that people use to manage their sleep, and it will help people fall asleep when they are right after drinking alcohol, but it also disrupts sleep. So you get in a pattern of early awakening and end up with worsening of sleep disorders. So we really have to think about when someone is using alcohol for sleep or mixing alcohol with medications for sleep, the opportunity for complications. So here's OP. She's an 80-year-old female, and she lives in an assisted living community, and she experienced a fall in the evening, but she wasn't injured. So she had a medication review with a pharmacist, and her family actually was consulted about whether they had any concerns as part of this, because one of them was present, her family members actually, during the interview, and they said that she was loopy and she'd been out of it. Like they'd call and she just seemed loopy. But there hadn't been any recent changes in her medicines, and so that's when OP did mention drinking wine in the evening. And then the medication technician who works on the floor stated that she stays up all night drinking wine and watching TV and then sleeps through the day. And when she's awakened to answer the phone during the day, she is sort of out of it. The medication technician wasn't sure how much she was drinking nightly or whether she was drinking more than usual. But she takes 16 scheduled prescription medications and has 5 as-needed medications, so quite a little list. And here's some of the medications she was taking. And we can point out here a lot of antihypertensives, which can, of course, she could end up with too low of blood pressure. We also see that she's taking antidepressants like citalopram or bupropion, and quetiapine, it's an antipsychotic, for depression, so multiple psychotropic medications. She was taking trazodone for insomnia as a sedative. She was taking tramadol, which is for pain, and I mean quite a few pills here that have the potential to interact with alcohol. So in this case, what were the signs that OP could be experiencing a medication-related problem? And then you can start typing in your recommendations for her as well.
Excellent. Okay, so here we see again, and this is choose all that apply. What are the indications of medication-related problems? Falls, living in an assisted living facility, being loopy and out of it, excessive daytime sleepiness, and watching TV all night. So please take a minute to respond to the poll and also posting your strategies. You know, I was also encouraged to see in the previous suggestions that there were folks that recommended some talk therapy and behavioral therapy. And, you know, particularly in terms of relocation adjustment, moving into a retirement community. I think that is something that we need to spend more time thinking about.
I think so too.
I'm so, you know, these cases are so good, Dr. Sladum. Thank you. Okay, so we're getting strategies and we have responses to our poll. So the number 1 response, 98%, being loopy and out of it, followed by excessive daytime sleepiness, followed by 92% falls, followed by 61% watching TV all night, and then 23% living in an assisted living facility.
Right. So I would agree with you. These, again, these geriatric syndrome-looking things, falling, being sort of out of it or over-sedated. I mean, these are things that always should be clues to us that we need to get to the heart of what's going on here. And when you are working with older adults, I, in my own practice, do quite regularly, we cannot assume that these things are just normal. And I know patients are doing it. I know their families are doing it. We have to really guard against that, I think, because sometimes it's like the underlying issue that's happening in this case, which is the fact that alcohol is being mixed with a number of medications. And we talked about what some of those that are really risky potentially are. And she was, I actually went back to see her to start getting at what we might want to do about this issue. And she had a glass of wine in her hand, and as she was, this was during the day actually, she had a glass of wine, and it was tilting as she was talking to me and spilling. And then I noticed that it's on the floor, it's around. I mean, she's obviously having trouble, and it's time for us to really see if we can't get her some support. So what recommendations do we have?
Well, okay, so lots of really excellent recommendations, particularly around improving her sleep hygiene and also finding, similar to what was said for the previous case, finding out what would motivate OP and having more structured daytime activities to find out what is the reason that you're not looking forward to things during the day that you're willing to sleep during the day.
Yes, yes, that's a very good point.
I'm so encouraged too that you and also our participants are bringing up the point that this is not a process of normal aging to be loopy and out of it and to sleep all day.
No.
Okay, lots of recommendations for medication review.
Yes.
Yes, exploring lifestyle and educating about the impact of alcohol.
Well, you all are bringing up a really important point that I want to emphasize here, and that's that really getting to the root of these problems and making changes that can help someone's quality of life in achieving their goals, and usually their goals of independence and autonomy and that sort of thing. It really takes far more than just a medical approach. I mean, sure, as a medical provider, we can advise people not to mix alcohol with their medications. But when we think about interventions like motivational interviewing and things that we can use to help people move to a change that ultimately is congruent with achieving their goals, then we will have accomplished this. And it really takes a team effort. And I'm talking everybody on the team, from the patient to the family to all of us as various providers. I mean, we all can have a piece here, either as the one who identifies that there's something going on. I mean, gosh, it was the companion at the home of BW that figured out what was going on. I mean, or stepping in and making sure that the right support pieces come into play. And I think oftentimes we never pull that team together to really make these things happen.
You know, one of the other responses is also that, you know, she has to be ready to make a change. Yeah.
She does need to be ready to make a change. And it's often
all
when
the
you
peeps in the world aren't going to make that happen if OP isn't interested in that.
No. And so we have to think about why, I mean, that's why exploring these goals and what people want for their lives, because one thing we're not in the business of doing is micromanaging people's lives for them. We really, though, when we can understand the goals and really get to the heart of them, if alcohol is getting in the way of achieving them, then that's where we have an opportunity to help make a difference for that person. So I would agree. And this is one of my favorite quotes. Putting the pieces of the puzzle together to create a solution remains a formidable but not insurmountable task. When we look at these things, I mean, yes, the complication of mixing alcohol with prescription medications, but that's just one piece for these patients, is that it's complicated, but that doesn't mean we shouldn't engage. It really does remain to us, along with our patients, to get to the heart of the problem. If it is a problem, I guess we should have that caveat. So let me go back to what happened to BW. So during his hospitalization, he abstained from alcohol. His medications were adjusted. He got home. His heart failure symptoms and mood improved. His gait and balance and functional status improved, and his family support and companion services were expanded to assist with medication adherence and to monitor his alcohol use. So he actually was able to get back to a much better place with the right help at home, because the caregiving had become quite high for BW, correct? And so I'll share with you that why I've gotten so interested in this topic is that BW is actually my own grandfather. And he, you know, once we really got realizing what was happening and were able to get the pieces together, the outcome actually turned out to be pretty good in the short term for him. And so it is possible for these things to change and for good things to happen in people's lives. When we're in the business of making recommendations for older adults about what is considered safe alcohol consumption, the National Institutes on Alcohol Abuse and Alcoholism does have drinking guidelines for older adults that say no more than 7 drinks per week, so on average 1 drink per day, with no more than 2 drinks on the same occasion. And what I really love is it says somewhat lower limits for women. And what somewhat means is still a little fuzzy, but we know that these effects on body composition and whatnot do affect women more than they affect men. So we do recommend that women consider a smaller amount, and we really have to help people understand what a drink means. So how much is a drink, one drink of wine? It's less than what most restaurants put in a wine glass. And, so 4 ounces of wine, the 12 ounces of beer, the 1 ounce of hard liquor. I mean, really helping people to understand that, because my own grandfather said, I only drink 1 drink per day. But he was filling up the entire glass with 9 ounces and straight with bourbon. So that's more than 1 drink in this definition. And we also have to think about the concurrent medications on top of that, because the concurrent medications change the risk. And if we think about all of this as a risk-benefit, and there are health benefits associated with the consumption of alcohol at moderate or modest levels, it's really when it exceeds that, and exceeds that, the definition or the threshold is moving as we get older. So it becomes more risky the older we are for the same amount of consumption. And so modest means no more than 1 drink per day usually, and I think that's not a bad advice to give to people, but it's not the only means of having wellness promotion. Staying engaged, exercising the body, eating well, those are things that can have as big or bigger, certainly, impacts than adding alcohol to our, especially when we are also consuming medications that put us at risk for having an adverse event. So reading the warning labels, don't mix alcohol and medications before seeking advice about what the consequences might be. And what are some of our take-home messages for today? For family caregivers, or for those of you who are working with or know someone who is having a potential issue, it's important to face the problem. And I can say as a family member myself where this has been a concern, it is important to face the problem and to be direct. It's not easy, but it's important. And being supportive without being enabling, and really understanding when it's moving to being enabling instead of supporting. Offering encouragement, praise, and encouraging the connection with community resources are all ways that we can, as family members, help to achieve a healthier point. We have to realize that we can't do these things without the sort of collaboration with the person we're concerned about, that it will take some working through the issues. I know for my own family member, one of the things that he said was most important to him is that he really did not want to lose his independence. And when he really was kind of confronted with thinking about his alcohol use as totally getting in the way of that, then he was able to kind of step back for a minute and be a little more objective and move towards a healthier life and outcome. We also have a few takeaway messages from today for professionals in the field, and that's that it is important to discuss alcohol use with our clients and patients. It is uncomfortable often to do that. Sometimes we don't do a very good job of training health professionals on how to engage in these conversations, and we have, of course, some health professionals who are experts at doing this, and when referrals to those kinds of services are needed, we should be doing that. But also just being willing to talk about this in the normal context of the patient interview and encounter. Referring to a pharmacist or the prescriber for specific advice about the safety of mixing particular drugs with alcohol is also important. Learning to use screening, brief intervention, and referral to treatment, so SBIRT, as a way of helping patients move towards healthier relationship with alcohol, especially as it's being mixed with prescription drugs. And it's important as professionals that we know our community resources so that we can help people get connected to them, rather than just tell them that maybe they should think about this, helping them to know exactly where they can go for help, or even making that connection more real is important. So these are just a few of the things that we might think about, and I'm very interested in your feedback about other things that you might include on either of these lists as ways that we might all do our sort of team effort to help this problem to become less of, I'll say, the less result in these bad outcomes that sometimes happen, like falls and fractures, automobile accidents, etc.
Well, we do. Thank you, Dr. Sladum. This has been very informative, and I can tell from the responses that people are getting a lot out of this. And I know we'll have some more questions coming in, but just to get started with some of the questions that already are coming in. This is a pretty basic question, but I hear this a lot, and it is something that I think professionally we're all wrestling with. And I'd be curious from a pharmacist standpoint, what do pharmacists consider as older adults?
Well, I think any of us who work in the older adult kind of community, that is not a consistent definition that people have. And I think that we all can kind of realize now that for the healthy person, 65 is the new middle age. So where do these physiologic changes actually really become apparent?
Right.
It's often older than 65 for some people. But there are other people who, because of their chronic health conditions and other things, they age almost prematurely. So this is a very this assessment really shouldn't be about chronologic age. It should be all about this person's circumstances. It's a very individualized thing. So I find it difficult to say that there's a rule for a cutoff, and I would guarantee you that pharmacists don't have the same definition that they would use, depending on how familiar they are with gerontology and geriatrics. I mean, it's somewhat easy sometimes to say, well, if you're over 65, this should happen. You know, we should apply this rule. But really, there needs to be some individualization in that assessment.
Yeah, I think that's a helpful, actually, response, because it does seem to fit with the theme that you've been mentioning throughout this presentation, that, you know, we can't blame things on aging. We can't say this is normal aging when clearly it's an indication of some other underlying problem that we need to attend to. And along that same line, we can't point to a specific age. Would you say a little more about the SBIRT for folks who may not be familiar with that?
Well, what I can say about it is I've been to one training myself. That does not make me an expert. But the principle of it is doing some screening in the context of the encounter with a patient or a client. And when issues are identified in the screening, a brief intervention that occurs, similar to the vein of motivational interviewing, which is helping people to recognize that there is a disconnect between what they say they want and what they're actually doing, and then making sure they're getting referrals to the appropriate treatment. And I was actually thinking about this as I was preparing for the webinar. Wouldn't it be wonderful to have some follow-up kinds of discussions related to that specific intervention? Because there is a good evidence base for it working, and you can go online and find out some of the characteristics, but it helps to have a training and practice doing it. And it's really something that this isn't something that just happens in a doctor's office or in a psychologist's office. You know, it really can be something that happens in lots of different settings where we encounter and engage with older adults. And so I kind of encourage people to really investigate this and take a look at it and its applicability to their own practice environment.
Well, that is very helpful. You know, from time to time we do follow-up webinars to topics that have been brought up. So if folks are interested in that, that is something that we would be willing to do. Okay, one final question, because we are running up against our time, but I like to make sure we get these in, as many as possible. Do you see a big difference between medication-related problems for older adults who have been lifetime alcohol users, and I'm not saying abusers, lifetime users, and people who are late life initiates of alcohol use?
You know, that is a really interesting question, and I have not seen a lot of literature on the differences, except to say that the impact sometimes of an acute drinking episode when there's not been alcohol in the body for a while can be quite different on things like drug metabolizing enzymes than if you are a chronic user. Even if that chronic use is just a drink per day, your body has accommodated to that. And so we also know that there's a phenomenon of tolerance that develops with drinking, and people can build up so that they are consuming a good bit of alcohol and still behaving what's seemingly pretty normally around them. And that can be very different than someone who would consume that same amount of alcohol as a naive.
Yeah.
Their effect would be quite different. But I haven't seen a lot of literature in that area specifically around how it affects drugs, except for this drug metabolizing issue. You know, how the liver it can get ramped up by alcohol being there all the time, and it can metabolize drugs more quickly.
Well, I think this question was probably prompted by your statement about alcohol, the comfort and familiarity of alcohol use in long-term care communities, and
yes.
I can see how that would be an area of interest for folks.
Well, and there's so many changes in late life that come sometimes that this might be something that people have not turned to in the past in coping, that they do in the face of the kinds of issues they're facing in later life. They're different than the ones they faced earlier in life.
Certainly.
Yeah.
And especially if the setting then changes.
Yes.
And, yeah, interesting. Well, you brought up a lot of very salient and helpful points. I know that our attendees have really enjoyed this. I know I always learn something when I hear you present, Dr. Sladom, so I thank you very much for this. So thank you for being here. Thank you to our attendees for your interest and participation and hanging in there with us today. I'd also like to give another thank you to our supporters. Again, this webinar was funded through a grant from the Virginia Center on Aging's Geriatric Training Education Initiative and supported by Riverside Center for Excellence in Aging and Lifelong Health and the Virginia Geriatric Mental Health Partnership, and of course VCU's Department of Gerontology. I hope that you will all join us again for our next section in this series by the Virginia Geriatric Mental Health Partnership, which is going to be on Thursday, April the 23rd, and it is titled Sexuality in Long-Term Care. And actually you see here on your slide the April 1 and the May 1 posted. Please don't forget to complete your event survey in order to receive your certificate of attendance. Remember that all of our webinars are archived for future viewing and sharing, so please make a point to share those with your colleagues. And I hope that you have all gained something today that will help you do what you do a little better. Thank you so much for joining us. Have a great day. Enjoy the rest of your week. Thank you again, Dr. Sladom.
Thanks, everyone.
Bye-bye.